leadership and governance, human resources, advocacy, medical supplies, infrastructure, quality, innovations, and monitoring and evaluation. This is a nationwide flagship kind of initiative, now 2.5 years under implementation. And in two of the regions, in Tigray and in Amhara, through funding from GE Foundation, the Safe Surgery 2020 program was initiated. The key players were JPIGO, Assist, G4 Alliance, and Harvard PGSAC program. JPIGO dealt with the leadership and governance pillar. The Harvard PGSAC dealt with M&D, and G4 Alliance somehow worked with the advocacy component. Assist is trying to do something regarding innovations in those two particular regions. And in one region, in Oromia, in Jimma, then Minilik and Blackline hospitals at the Addis Ababa University, Lifebox launched what we call the Clean Cut program. This is a program we devised with the main intention of reducing surgical site infections and mortality post-operatively by using the WHO Safe Surgery checklist. And the first work is published recently at a good journal. Then what has been happening so far has been published so far as a separate WHO publication and an article at the World Journal of Surgery. And as I really want to stress the fact that SS 2020 is working in two regions, in Amhara and Tigray, but the SOLTS initiative is a national initiative. So what we wanted to do now is follow what the government wants, what the Ministry of Health wants. We wanted to copy what is done in the two regions, modify it to fit assets pillars, and implement it at one of the regions, a selected region in the country. Why we selected this particular region is because we have a protected population under Addis Ababa University, where 5 or 6 hospitals are under our continuous surveillance. The questions we wanted to answer at the diagnostic phase include: what are the care pathways for people with surgical conditions? What are the health system bottlenecks? And what interventions would work better in those situations? The setting: we followed the Ethiopian Alliance for Quality clustering system. In this particular cluster, the Butajira Hospital, which is General Hospital, is supposed to support the 6 primary hospitals under it. In the Ethiopian context, primary hospitals are supposed to take care of emergency procedures, and general hospitals are supposed to do emergencies and electives. The bellwether 3 procedures are all done at primary hospitals. So we wanted to adopt the Butajira hospital cluster. Under these are about 15 health centers. The first activity of the diagnostic phase would be the stakeholders workshop, the theory of change approach, which Charlotte has clearly outlined in the morning. This will also be done in the surgical aspect. Then we will do what we call a situation analysis. What are the structural barriers to improving surgical care? This will be tried at the hospital level, at the 6 hospitals, and at the district level. In the hospital assessment, WHO already has a hospital assessment tool that Ethiopia has revised and adopted to fit its own. This will be revised to fit our purpose and used to assess the hospitals. Then we will try facility process maps. What are the pathways through surgical care? How can they be tracked, and what are the barriers? What steps or processes does a surgical patient follow through the hospital and after discharge? How long does he stay in the emergency? How long did he stay before receiving surgical care? What was the outcome? And a process mapping study and an observational study will be paired to address this issue. Then we will have a surgical cohort study. What will be the outcome of surgical procedures in these particular hospitals, in the 6 hospitals, particularly health-seeking behavior, satisfaction, client satisfaction scales, disability, and cost of care. Particularly, we are interested in the cost of care, where 2 of the Lancet Commission indicators will be tried to be addressed. These are catastrophic and impoverishing expenditures in surgical care. The 5th would be a community study. What would be the prevalence of treatable or unmet needs, surgical needs in the population? A similar study was done about 20 years ago in Ethiopia. And we have seen an important paper coming out from Sierra Leone of a similar sort, which will be a huge input to this. And we will adopt the SAS data collecting tool and the WHO verbal autopsy to identify possible surgical conditions related mortality in the population. The last would be a qualitative study. What are the care pathways for surgical care, impact of unmet needs, and barriers to accessing quality, timely, and safe surgical care in the form of in-depth interviews with a range of stakeholders and the population, those that receive treatment. Possible interventions, these include delineating and implementing care pathways. One important program we think will have an impact is the Clean Cut program that definitely will reduce surgical site infection mortality based on the checklist implementation. We will devise quality improvement projects. If possible, mechanism for communication of referrals will be thought of. Management and leadership structure of the hospitals can also be assisted. Capacity building is an integral part of this program. Unless the surgical workforce understands what global surgery means, what the numbers mean, what global engagement means, then the old thinking that if you operate patients, then you are doing your responsibility will still prevail. So the entire surgical workforce needs to understand what global surgery means. I am an example. 10 years ago, what I used to think 10 years ago and now are completely different. So wider engagement of the surgeons in the country will be targeted. We are thinking of establishing a global surgery, let's call it an office or a desk. And in conclusion, this is a great opportunity for surgical care in the country. There is already data coming out from certain parts of the country which can be used. Policy commitment is there. We have a representative from the ministry already here that shows significant policy commitment. There is challenge in front of us, but I think it can be done.